Okay, we're back, we're live, we're here, we're ThinkTech Thursday. Wow, exciting. And we're starting early today at 11 o'clock. So Christine Sakuda from the Hawaii Hawaii Health Information Exchange.
Yes, sir.
HHIE.
HHIE. Nice to be here today, and thanks for having me.
Thank you for coming down, Christine. And Joyce Lignell from the Applied Research Works. And that's a health IT vendor that is actually involved in this project we're talking about. Say hi.
Hello, I'm grateful to be here, so thank you for having me.
I knew you'd say that. Okay, this project we're talking about here on Hawaii, the state of health, is faster lab results for better health outcomes.
That's right.
Yes.
Health outcomes. So first, let's talk about, and you guys are not in the same organization. You're in the same initiative. We'll talk about the initiative, but you're in separate organizations. So Christine, tell us about the HHIE.
The HHIE, thank you, Jay. Well, the Hawaii Health Information Exchange, the HHIE, is a nonprofit organization that's committed to connecting physicians and hospitals and labs and really the whole healthcare community together to share information, medical information, in order to improve healthcare for the patients. So we are establishing an IT network that basically connects providers' electronic healthcare records together.
You're a tech organization.
Yes,
Yeah.
yes.
Oh, wow.
With a
We
community
like
mission.
So you make structures that make it easy to get information from all the health players on the table.
Yes.
And how old are you? Not you personally.
Well, we were established in 2006, and we have a very large board. We have over a 20-member board that includes hospitals, the health plans, independent physicians, the labs, but we also have AARW and the Chamber of Commerce on our board as well, because it's just so critical for the healthcare industry to be able to communicate with each other and share information, drive down costs, and help manage costs in the system.
So the people on your board, so to speak, the people that you are serving, that you are helping facilitate the exchange of information, are not limited to the people on your board.
No, not at all.
It's everybody.
It's everybody. In particular, we have, of course, we're located on Oahu, but we work very closely with the hospitals and the providers on all of the islands because patients move between the neighbor islands and Oahu and back again. And it's very important that the information moves with the patient, no matter where they're seen.
Oh, this is very modern. We need this.
Yes.
If we're going to be Hawaii, the state of health.
Yes, sir, absolutely.
So if I'm a doctor, say I'm a doctor practicing in Lihui, and I call you up and I say, Christine, I've heard about you guys, and I want to take advantage of what you have to offer. What's your answer to me?
Well, I would say contact your primary care provider and contact your internist and make sure that they know how important it is for you to have information when and where you need it. So no matter if you see your doctor in Lihui, or you happen to see a specialist on Oahu, or you happen to, head into a hospital for whatever reason, that any provider that sees you has that information that they need to treat you in a timely way.
Okay, so I mean, really, every player in the health industry, every doctor, every hospital, everybody is somehow going to benefit by the better exchange of medical information.
Absolutely.
Yes.
Yeah.
That's our goal.
Okay, and I guess I want to ask, in the larger question, what is medical information? Now, one of the primary thing we talk about today is lab results, which we made a movie once about diagnostic laboratories.
Oh, really?
So I'm kind of familiar with how that works.
Yeah.
But it just in general, what is health information and what role, where does lab results fit in the larger picture of health information?
Well, health information is anytime a patient seeks to receive care from a healthcare provider, there's health information that's generated. And it's important that the provider that is delivering healthcare has the information that they need to care for that patient. So traditionally, that's medical information generated by
To the chart
physicians.
in the physician.
But over time, that also moves to care coordinators and caregivers that's helping to manage the care for the patient. So there are extensions as well, and that kind of makes up the complex web of health information.
This was established, what, by the state?
The Hawaii Health Information Exchange was actually established by the private sector leadership, but we have a very close partnership with the state. The Healthcare Transformation Coordinator sits on our board, and we work very closely with the Departments of Health and the Department of Human Services, Medicaid in particular.
And there's a parallel, or at least a close affiliation, between the initiative you're involved in and what do you call it, electronic medical records, right?
Yes.
I mean, it runs they're kissing cousins, aren't they?
Yes, yes.
You really want them to be.
I really want them to be. More and more, about 60% of the physicians in the state of Hawaii have electronic medical records, which means that about 40% of them don't, and they're on a paper record system.
Those are the ones who are kicking and screaming.
Well, it's very difficult to implement electronic health records, and IT is really meant to help physicians, and I think it's an ongoing, lifelong process to innovate and always find ways to leverage technology to help providers. Sure. And I just don't think that's any one individual's or one individual organization's responsibility alone, which is why the partnership that we have with HMSA and ARW is so important. It does really take a commitment by the community to share information and deliver it.
Which is mostly the doctors.
Yes.
So now you're not, just to get the flavor of who you are, you're not associated with a federal organization.
No, the Hawaii Health Information Exchange, like I said, it's a nonprofit, but it did receive some federal funds to build out infrastructure.
Okay.
And so, infrastructure is very expensive to build out and very complex.
Infrastructure means computer infrastructure.
Computer
Yes.
infrastructure. And in addition to that, there's a lot of effort to bring the stakeholders to the table to agree on principles of how information should be shared, and the patient and the physicians in the community are very critical components of that.
Do you have anything to do with the Affordable Care
The
Act?
Affordable Care Act? We weren't funded through the Affordable Care Act, but we do support that. There are elements in the Affordable Care Act that speak to increasing efficiencies within the healthcare system, making sure providers have the information that they need to make good decisions that result in good health outcomes.
You figured that out before the Affordable Care Act.
Well, we are supportive of those aspects of the Affordable Care Act, and those movements and intentions of the Affordable Care Act really help to legitimize the reason why we're here, is that we really feel that we provide a great value to the community to network and connect through technology providers together to share information.
How big are you?
We have about 20 employees.
And where are you located?
We're located actually 13 floors up in the Pioneer Plaza above us.
What a
She had to
great
come down the
building.
stairs.
Yeah, we are impressed.
Yes.
We feel good.
Yes, yes.
Okay, let me turn for at least before the next break, a few minutes to Joyce. Now, you're also a private organization.
Yes.
It's Applied Research Works,
Yes.
and you're a health IT vendor.
Yes.
Tell me, what is a vendor in this context?
We're a health IT company that provides technical expertise, mostly to health plans. And we're actually a consumer of the data that comes out of the Hawaii Health Information Exchange. So we also work on behalf of HMSA in this initiative that we're talking about here today. So while Christine's organization passed us the lab data, we were able to take it in and present it through a web interface that we call COZEVA, which is
Say that again.
COZEVA.
Spell it.
COZEVA,
Okay,
COZEVA.
all right. So
Yeah.
they should know. Yeah.
COZEVA. And there's about 730 primary care physicians today that actually use this interface.
How many physicians are there in total in the state?
Physicians in the state, would you know?
It's not that many anymore.
Well, there is a physician shortage in the state of Hawaii. I think there are around 4,000 licensed physicians, and there's
that's what I was
about
gonna say.
1,200 primary care providers in the
Okay.
state of Hawaii.
Yeah, thereabouts, right.
All right, so,
Okay.
okay, so 630, was it?
About 700.
700, say 700.
Yes.
That is going to be about, what, I can't do the math.
Well, it's about,
Okay.
I mean, it's probably 70% roughly of the primary care, the active primary care
Active primary
physicians.
care, okay.
Right, there's
Well,
a
that's
lot
pretty
that
good.
are,
You're
maybe
still
not
out there
practicing.
recruiting, though. You're
Yes,
trying to get,
we
you
are.
both are trying to get them
Yes.
all in the pot.
Yes.
Yeah,
Yes, actively trying to bring them on board every day. So that's a large part of our job. And what we do is we take that data and we present it in front of the doctors so that they can see their quality initiatives that they need and need to be working on in this new.
So it's presentation.
Yeah, it's presentation, it's
You're
data
getting
visualization.
the raw data, and you're turning it around in a way so that even a complete Luddite doctor, they have those, can read it and
Right.
use it and,
Right.
and make it part of his process.
Exactly, and we try to make it as simple as possible. And while, and I have to say, today they get their lab results. Oftentimes, if they have an EMR with electronic medical records and they're able to take in a lab feed, a lot of them do get their lab feeds immediately from these labs directly into their EMRs. What we do in COSIVA is we are now, thanks to the HHIE, we're now able to pick up that lab result at the same time that the EMR picks up the lab result, and we are able to update those quality measures. So instead of them having to go wait for the lab result to cycle through the claims
They can get it early, they
validation
can get it earlier.
cycle,
And then they get it from you, it's better.
it's not better, it's more timely.
Oh, you're the earlier one.
Well, we get it the same time as the
When you
the
present
EMR.
it to the doctor.
Right, it just is presented differently. When they get it in their EMR, it's giving them a piece of clinical information to make decisions. When they get it in COSIVA, they're also getting a piece of clinical information, but it's updating a quality measure that's really tied to both quality outcomes and payment.
So how is it different? I mean, it's color, for example.
How
I'm
is
joking.
it? Yeah, yellow instead of orange, right? Yeah, it's just a different way of looking at the data. What it does is it shows them that a certain measure has been achieved. They don't have to think about it anymore. So, like, for example, if I need to go to the lab to have hemoglobin A1C done, because maybe I'm a diabetic. So I have that, I go to the lab, I get that done. The doctor gets a result into his EMR, but they also get it into COSIVA now, thanks to the HHIE. And that quality measure that's saying Joyce is a diabetic, she has these outstanding tests that need to be done, you've got to see her. There's these bars that red, yellow, green that say you got to do something or you don't have to do something. This lab result now comes in a very timely way, so the doctor knows very timely, Joyce is done.
So
I don't
you're
have to
telling
think
the
about her.
significance of the data.
Very
For example, if the reading, say a bad reading, is really high, you're going to tell them that. You say, watch out, this one, this is
The lab result will tell them that.
Okay,
right.
well, what do you add to that? You're comparing it against another one?
No, we don't compare any results.
Sorry, I'm thick about
That's
this.
okay. No, it's okay. What we're really doing is we're helping on the side, think more towards the side of revenue in a new value-based purchasing environment. So now a doctor doesn't just get paid for seeing the patient. This doctor may also get paid for seeing the patient and ensuring that this patient is getting all the right care that they need for the best quality
So
outcome.
you're helping them on medical decisions.
I think one thing to add that is that the product helps to manage the provider's patient population. And so it's
Yes.
the information can be used in different ways. The HHIE deals with a lot of real-time data, very episodic data. You come in, you need information to be treated, and hopefully that information is there.
Right.
And that's what our network actively supports. And that's different than perhaps HMSA, again, being the steward of our initiative together, is helping providers and patients manage their health. So that's just not episodic, one visit at a time.
Right.
But
It's a continuity.
it's
of
a
comprehensive-
continuity in a
yeah.
series of visits, and how are they progressing over a series of visits and over time, and how do we create a support system that helps providers to manage their
It's the delta
care.
factor,
Yeah.
Yes.
changing.
Yes.
Okay, let's take a short break, and then we'll come back and we'll try to put all of this together.
Okay. Sounds good.
It's Christine Sakuda from the Hawaii Health Information Exchange, and Joyce Lignell, Applied Research Works, which is a health IT vendor, and we're talking about faster lab results for better medical outcomes here on Hawaii, the state of health. You bet. We'll be right back.
Hi, I'm your host on ThinkTech Asia, Bill Sharp. I look forward to you joining us each Monday between 4 and 5 o'clock when we film right here in our studio in downtown Honolulu. The show, ThinkTech Asia, focuses on contemporary events in Asia, and by Asia we mean anything from Hawaii, south to Australia and New Zealand, west to Pakistan, and as far north as the Russian Far East. Clearly, this is one of the most economically dynamic centers of the world, and we bring you up to date on what's going on in a whole host of countries in this very vital region. We look forward to seeing you. Aloha.
Okay, we're back. We mean it. We're learning. We're always learning. We're learning about health today. We're learning about lab results. We're learning about organizations, agencies that are collaborating. Very important work. Sort of a new dawning, a new chapter in health for Hawaii, which is really a healthy state. Good for us. Good for all of us. Good.
Right.
And we have Christine Sakuda from the Hawaii Health Information Exchange, and Joyce Lignell, who is with a health IT vendor called Applied Research Works. So to continue a little bit on that, to try to get the comprehensive on it. So you're one of many vendors, or are you the only one involved?
Well, in this case, we're the only one involved, but there are many vendors like us. We just happen to be the one that's servicing. What's missing at this table is HMSA, and
Okay.
it's really their story. Christina and I are probably not doing the best job trying to tell.
They're always with us.
Yes,
They're always with
they're
us.
in our hearts.
We carry them in our wallets.
Right? They're the reason we do all this, and really, I could never do justice in speaking on their behalf, but certainly their whole goal as a health plan organization is to not only support the healthcare environment, but also to affect change and to create some cost sustainability. With the ACA changing more to value-based purchasing, driving more that value-based purchasing environment, the work that Christina and I have done in terms of, and I don't mean just her and I, it's our teams that are behind us, to really bring these lab results into COSIVA on behalf of HMSA and all the providers that service that HMSA network. It really helps those doctors to see in more real time the goals, the quality goals that they either need to work on or that have been fulfilled in a more timely way. These lab results will close out a goal saying it's done, check, Joyce has got everything she needs, or Christine does not have everything she needs. So this helps bring it into a more timely format.
Okay, so, but now you have the information. You're getting the information from your participants. You're helping to translate the information,
Yes.
Process it
And create
for presentability
Yes.
and for a better view by the doctor.
And it can be acted on, right?
Acted on.
Right.
Okay.
Yeah.
Where's HMSA fit in there? I mean, they're paying, I suppose, but
Yes.
where else do they fit?
Well, I think that they're they're a critical stakeholder, and like Joyce has said, there are, the person that's actually, or the stakeholder that's missing at the table today, but they are a large health plan, and anyone in healthcare nowadays is really, looking for ways to deliver better care to the patients, to support the physicians and their ability to make informed decisions. And information has the opportunity to supply that. The Hawaii Health Information Exchange does deal with real-time data, and we have we also have a web portal that's called a community health record, but that's very episodic. So it helps the physician look at the patient when they're in their office, what labs have they had to act upon. I think in addition to that, there's more of a nuance to what Joyce has said, where if you want to look at information over a time, or that with a combination to manage, for physicians to manage their patients, how well are my patients doing? Do I need to bring them in again? How are they doing in their diabetes management program? Are they sort of tracking correctly? That's important as well.
HMSA, though, I mean, we know that they're paying because it's part of insurance, but they're not getting the information itself, right? It doesn't go to HMSA.
No, it goes out to the provider.
It goes to the provider.
Yes.
Does it go to me, by the way? If I call you and I say, you know, Joyce, I'd really appreciate it if you just copy me. Would
So
you?
I actually have an answer for that. If you're an HMSA member, HMSA, we are collaborating right now with the release strategy for that health information, those lab results, down to the member. So if you are an HMSA member, you at some point will be able to take advantage of these lab results that are coming through, and we're in that process right now,
Directly.
deciding.
I can go on my
Not
browser.
today,
But it's coming.
It's coming.
It's-
Yeah,
it-
there'll be shortly the second part of that.
This is
story.
good, this is good. I mean, you know, you guys must know Hilton Rayfield.
Yes.
Was he the one supposed to come down today? Okay, maybe.
A representative from HMSA.
Okay.
We're not sure. who-
Somebody.
Yeah.
But, I mean, you know, he's been in a number of our programs on health.
Yes.
Luncheon programs and so
Yeah.
forth, and here. And, I mean, he's always saying, you know, the things you're saying. He's always saying, we need better communication, and we need the patient to understand that he's responsible. We want to bring health and wellness to everybody, and that's our primary mission. So I guess what I hear you saying is that HMSA is important because it's saying, yes, ladies, do this. We want this. This is part of the system, and we're going to encourage you. We're going to pay the claims on it, whatever it is. And we see this as an essential element in Hawaii's health system going forward. And we, of course, are HMSA. And it means a lot what we say.
You know,
Am I right? I mean, am I getting
yeah.
this right?
Yeah, I mean, they're very, I would say, and I'm sure Christine, you've seen the same, they are very dynamic. They're in this community. They're very innovative in how they think about healthcare, how it can be better served, you know, where are those points where there can be more efficiencies gained, where costs can be more accurately managed. You know, these are all among many other dimensions that they think about.
Okay,
Yeah.
so I'm just tracking what I've heard today. I'm a Carta Blanca here. So the doctor, maybe one of your directors or not at the Hawaii Health Information Exchange, puts in records on me, and that goes to your system, your service system?
That's what we're working towards. So we
Okay.
can't get everyone connected at the same time, and everyone has different levels of connecting. But ultimately, you know, I guess the answer is yes, we'd like that, but it depends. And the reason why it depends, and a key factor of that is related to a value that we have of respecting the data and protecting the data.
Right.
So it's not HHIE's data, and in fact, it's not the physician's data, it's
You
the
hold it in
patient's
trust,
data.
yeah.
And so, you know, that's just part of the value system of the HHIE and the data governance of the HHIE. So I think that over time, we'll have a process and a roadmap to talk to every provider and work with a provider to have them get connected to the HHIE and to share information.
Okay, but does sharing mean a direct share, or does it mean a server somewhere?
I think it's both, and it depends on the readiness of the provider, and then how they associate with their network of other providers. So some of it is just something as simple as a secured email system, so that I can share information. I want to send you my patient. I need to get information to you. I want to share that information. And then when you're on the fly and you have your iPhone or iPad, you know, you don't want to breach any privacy and security concerns. So that's very simple as that, to something that's much more sophisticated, where you're sharing discrete data out of the system to the HHIE. Now, over time, that's sort of where we'd like to get to, because that provides us opportunities to manage the data better and deliver that in terms of information to the physician.
So the operative word is management.
Yes.
You're managing this data
Yes.
for the benefit of patients, for the benefit of these IT vendors, because you're pulling it out
Yeah.
and you're processing it, and you're delivering it in an improved form to the doctors.
Yes.
Yeah.
And one day, everyone, maybe sooner
Yeah.
than later. Okay, so now, in the data somewhere are lab results
Yes.
from two laboratories principally, diagnostic laboratories, and what's the other one?
Clinical
Clinical
labs.
labs.
Okay, and they're both right here in Honolulu,
Yeah.
and they do testing for a lot of people not only here in the state of Hawaii, but all over the Pacific. I know that.
Yes.
Yeah.
Okay, and they are on your system. They are part of that data that you're managing.
Yes.
Okay, and you're getting, and I don't know clinical, but I know diagnostic is very efficient, very high-tech, modern, you know, have you seen them?
They're
It's
amazing.
very-
I've been there.
It's really beautiful.
It is a beautiful
And the
facility.
people
Yeah.
are very dedicated.
They are.
And they do so much. I mean, it's surprising all the
Yes.
things they cover.
Yeah.
So anyway, so now you're getting that data, right? It's going into the system that you manage.
Mm-hmm.
Now we're here to talk about, it took us 20 minutes to get to this, but we're here to talk about
Yeah.
the fact that you can make it happen faster.
Yes.
And faster is better. How do you make it happen faster?
Well, the way we make it happen faster is building an efficient IT network between the labs, HHIE, and moving that data to ARW for their COSIVA system. Today, or I should say, you know, before today, while we're here, the labs did share that information with the HMSA and fed the products to support programs, but not in real time. And so whenever there's a lag, then there's a delay in an ability to make informed decisions.
Yes.
So our IT infrastructure enables the data that had already been going to move faster.
Real time.
Real time. So
That's the big
it
change,
supports
real
an
time.
efficient system, a more efficient system.
Okay, now you're not getting it any faster, but you're sharing it immediately. Or are you also getting it faster?
Between the laboratories and the HHIE we've always gotten it real time because that's our mission, that's what we do. And then we work very closely with HMSA and ARW to develop a structure where they can get that information real time.
It was us who was not getting it real time.
Right.
They've
Right,
always been
right.
real time. And I need to make a clarification just because DLS and clinical labs are not here. They've always produced real-time results that can pass directly to the EMRs and EHRs. So they do their job always as efficiently. Nothing that we've done impacts their very efficient operations that they maintain. What has changed is the latency of data getting into COSIVA and updating quality goals and you know, more timely information for the doctor to act upon or the practice staff to act upon.
Now, when that came from you guys said, gee, it would be better if we had it real time. And then you went to Christine.
No, well, we are also, our system is also a real-time system, but
Yeah.
we are dependent upon the health plan and the data feeds and the timeliness that they give those feeds to us. Things like claims feeds, lab feeds. We were getting them directly, we were getting them as a pass-through from HMSA. And so what's improved, really, for this story, what's improved is our ability, ARW's ability to receive a real-time data feed from the HHIE instead of having HMSA be the middleman where there's this tremendous
This is really
latency.
good.
This is really good.
So instead of you having to wait, I don't know how much you would have waited, but say a day, I don't know, before you got it in your machine ready for you to process. Now you get it essentially the same time, because
Right.
real time is the same time, right?
We actually got it like a month after
Oh,
the fact.
gee
It was
whiz.
like, we weren't even, we were like, you know, iceberg time. It was, you know, and it really affected the doctors because as they're in a, you know, in the race to, you know, deliver this quality, more proactive care to their patients, they're waiting to see if that patient in fact did something. And sometimes they're waiting a
That's a
month.
long
You
time.
lose, there's a lot of lag in the system, and that lag affects the efficiency and better care of the patients.
Let's talk about that. I mean, let's talk about how real time changes in lab results,
yeah.
changes the practice of medicine. And I'll tell you my reaction that I gave you before the show is that I believe that modern medicine is all about lab results and metrics, and the doctor, my doctor, you know, gives me a sheet. He says, here, this is all your lab results. I'll go and read it, look it up, you know, and find out what's.
Yeah.
I mean, and that's what he processes. That's what he looks at. In fact, I'm not sure I even need to be there. You know, he just has all these numbers, and that's the way modern medicine, especially you know in the primary
Yes.
area, is concerned, is practiced now. So it seems to me that what you have done to make it real time on both steps is really dramatic for the primary doctor.
Right. I mean, I think, just to always sort of harken back. Their process, is very good. If they have an electronic EMR, they were able to get that real-time lab result and act on that with you, the patient. And so the piece we play is really helping to bring that whole picture together and give them the complete story. So you've got your clinical story happening through your EMR. Through COSIVA, you're seeing kind of more the goal-oriented, value-based story of, are you giving all the right care at the right time, including all the preventive care that needs to be delivered.
It's a number of things.
It's a
not
number
just,
of things. Doctors, and they are very burdened in this new system with all these new ways of not practicing medicine, but really running the business of medicine.
Yeah.
And certainly COSIVA presents, it's the face of a lot of those new workflows that have been introduced as a result of, being paid based on outcomes versus just filing a claim for seeing a patient.
So when I come to my doctor, my primary's office, and I cool my heels for a long time, waiting, I'm sure we all do that.
Yeah.
He's in his office, and he's trying to get a handle on exactly how I'm doing before he sees me, right?
Right.
And he goes and he looks at his computer, and he looks at your stuff, and that'll give him a fast and accurate and more comprehensive,
Yes.
and a sort of tracking on the graphs and how it's changing, the delta factor.
Yes.
And so when he comes out to see me after that inordinate period of time, then he's ready, because he's looked at my chart. It's not like he just came directly from playing golf. Sorry I said that. But he is actually looking at this stuff,
Right.
and he is ready to talk to me intelligently, having seen not only the results, but a certain amount of the interpretation of the results and the comparison and the charts and
Right.
graphs about the results. This is very important, especially when, and we can talk about this after the break, how the practice of medicine in general has changed in the past few years. And you guys both represent that kind of
Pieces of
change,
those
kind of
changes,
deal
yeah.
with that change. You referred, and I thought it was very gracious the way you put it, the problems in the, quote, business of medicine.
Yes.
And we're going to talk about it when we come back.
Okay, great.
Great, thank you.
Okay, that's Christine Sakuda and Joyce Lignell here in Hawaii, the state of health, talking about faster lab results and how they result in better medicine here. We'll be right back.
Aloha, my name is Josh Green. I host a show called Healthcare in Hawaii here on ThinkTech. We get together once a week or sometimes twice a month. Depends. When we're busy, we get together less often, but we love to see you here to talk about the preeminent healthcare issues in our state. Our programs vary very widely. We talk about economics, we talk about healthcare, we talk about social issues on this program. Thanks for joining us.
Aloha, Yappers. This is your host, Kingsley, for the Yap Show. Every Friday, 3 p.m. to 4 p.m. Eastern Time. You can catch us here live, ThinkTech Hawaii, and then later on we upload to our YouTube channel. We talk about youth issues, policies, youth programs, and how to transition yourself into adulthood.
But this was like a sign, I guess. Hey, Mike's like, hey, right. Now's your chance to go back to school, which I'm doing.
Catch us here again live, 3 p.m. to 4 p.m. Hawaii Standard Time. Aloha.
Okay, Christine Sakuda and Joyce Lignell are talking about lab results and how faster lab results result in better medicine for you here in Hawaii, the state of better health. So you were talking during the break, and I'm going to try to capture this before you forget, about, I said, gee, sometimes I pity the poor doctor, because he's got all these obligations, and he's got all this paperwork, he's got all this risk. It's every risk in business plus. Really, when you compare it against the ordinary widget business, there's no comparison. He's got a much harder time. And you can see them, if you know them over a period of time, you can see them getting older and frayed. They work a hard day. They have people out there hanging from the chandelier out in their waiting room. And it's all this pressure. So you were talking about that.
Yes.
And describe your picture of it.
Well, and this was actually born out of a presentation I saw, and I'm going to apologize now, I can't remember who gave it, but they did this great graphic where it talked about, it was a triangle, so think of a flat-end triangle coming down to a point. And they talked about how healthcare really has the blunt end. It's all the policymakers, CMS, state government, local government, and then your health plans and all that administration that happens and all these rules that are changing. And it all has to flow down from this very blunt end all the way down into this very sharp end of the triangle. And all those policies have to turn into work. At the end of the day, all this information and ideas and policy has to turn into work at the point of care. So you think all of that has to be materialized by that primary care physician, and that's overwhelming.
It is. It is absolutely.
Absolutely, and that's I would say that's what spawned. Why COSIVA was born is to kind of actualize a lot of that new payment models, new ways of being paid, quality, costs, risk. All of that stuff is materialized in a single user interface.
This is like a collective technology to the rescue, really.
Right.
Because the system, can't work with all those pressures. It can't work without technology. So you guys are coming to the rescue, not only the rescue of the doctor, but the rescue of the patient and the whole system.
But I would say it was not just only Christina and I. I mean, like I keep saying, the part of the team missing here is HMSA, because really it was them being concerned with all these changes, hitting that sharp end of the triangle, and knowing that was going to be just overwhelming. And how could a primary care physician even succeed in the face of all this change? How can they see what to do? How do they know what to do?
Who's winning the race?
Right, and it's really them that's championed a lot of the changes that you see today. Certainly this collaboration between the HHIE and ARW and COSIVA being placed in the doctor's office. It's a combination of all that.
So I want to ask you, the perfect world is where everything is real time. The perfect world is where he sits down in those few minutes between patients and he gets a complete picture and he comes into me, he's ready. He knows exactly what. And in fact, it's not only the lab results, it's not only the information from the medical records in general, it's the whole Merck manual. It's the physician's desk reference book. Everything is right there, and it works automatically for him. And that leaves a certain amount of risk if you rely entirely on that. But he's got his whole medical training is right there, so he can do a job faster. He can handle more patients. He can make fewer errors. It's a great thing what technology can do, but we're not home yet. You alluded to that. What do we need to do to get to the perfect world here? And what stands in the way of all these agencies, including HMSA, coming together and making this the best system in the world?
Wow. Okay, Jay, thank you for
Sorry
that
I
question.
asked that question.
Well, I'll give you my perspective, and that is that it's going to take us a while. I mean, healthcare is made up of, as far as infrastructure goes, it's made up of many different electronic medical records that weren't really set up to talk to each other. And in addition to the fragmented electronic health record, the many electronic health record systems across the state, we have about 30, there's still a portion of the physician population that is on paper. So we are all committed to moving towards connecting the physicians together electronically, because I think we see the value in delivering that. And a lot of things need to be in motion to do that. One, a commitment to connect is one. We can't force physicians to connect. We can't force or hospitals to share information. They have to want to do that and believe in doing that and have maybe some financial incentives to do that, that really help them with the cost, to defer the cost of technology, and then really reap the benefits of all the information that it provides. So I think we're working towards that.
What stands in the way, Christine?
Well, I think one is the fact that there are so many EHRs and electronic health records. So how do we minimize the amount of electronic health records that are out in the community?
Is there a consolidation going on?
There is a consolidation going on. The federal government is committed. Part of it is through the ACA, but not only, but the federal government is committed to developing standards for interoperability, so that it imposes upon electronic health record vendors and any health IT vendor. You have to be able to, your system has to be able to share information. Right. And you have to be able to share information in a standard way, so that even if you do have a different electronic health record systems, that they're able to connect. And so I think the federal government is trying to lead that, because in other countries, there's just one electronic health record system,
really?
and it makes it a lot
Like
easier.
in Europe, for example.
Right.
Yeah.
But in America and in Hawaii, we still have many different electronic health record systems. And for the small independent physician who might have an older electronic health record system, the demands that Joyce was saying of the healthcare industry starts to be very, very burdensome. So I think naturally there will be attrition of electronic health record systems, and there will be consolidation of that. And I think we sort of welcome that from an interoperable standpoint.
Sure.
But I think the other point that's important is physicians' willingness to share information and trust that system. So then you kind of
Hit him on the side of the head.
hit them on the side of the head. Okay, let's see if that works. So,
Old tech.
Well, I mean, I think medical schools are probably teaching more electronic medical records than
yes.
ever.
Yes.
And encourage, I'm sure JABSOM does that, it's pretty advanced, and so the next generation of doctors who, they're pretty impressive, they come out of JABSOM actually. That's because there's 57 applicants for every seat, that's why,
Right.
that's what happens. But the next generation will solve this problem for you. The old generation, the Luddites, will go away, okay? And then, I take a wild guess and see if you agree, 10 years' time, we will have a generation that's much more, willing to take the risk and put the time and money in to make a modern system in their office,
Right.
and cooperate with you guys.
right. I mean, the physicians more and more are definitely technologically savvy.
They are, yeah.
Right? They have their iPhones, iPads, and
They're coming along.
they're
Yeah.
they're
What about
very
the staffs?
interested. Their staff too.
Yes,
Yeah.
very much. In fact, their staff is very involved in our system. I think even in yours. They're actually the bigger user group is really the practice staff more than the physician.
Everybody
Physician will
knows
get
the
in there.
practice staffs really are the ones.
They're
that
the
make it
ones,
happen.
man. They're the workhorses.
Yeah.
You gotta
Here's
love
a
that
shout
practice
out to
Going
staff.
together.
practice
That's
Yeah,
right.
gotta love them.
So what about now? I'm really excited about IT, ID vendors. Did this area exist, 15 or 20 years ago? I don't think so.
Not-
maybe
and it was-
not even 10, maybe.
Yeah.
And now you have, probably a consolidation in that area too, and more sophisticated, and it's more important what you do.
Right.
So in the model you guys are describing, where we reach for nirvana, it does involve the three legs of the stool we're talking about.
It
And it
does.
certainly involves the IT vendors. And that sounds like there are all kinds of careers coming online that I should
Definitely.
consider.
right.
Tell the young people what kind of careers are available in IT vendor for health.
Well, I mean, certainly we need engineers that can think along a combination of business and technical lines. So when you're interfacing with a customer on the business side, say the health plan, you can take, so business analysts would be one. That's a very big need. The other one that we need are just pure engineering talent. So people who can work behind the scenes, work with, I'll tell you, the real hot spot is big analytics, big data. So being able to take in all these large amounts of data that maybe come in from the HHIE or other sources, and to be able to, do all the stratification across that data and wring out of it very meaningful information that can be acted on.
And
That's
this
very
actually
important.
opens a whole new area, which we haven't talked
does.
about yet today, is community metrics.
Mm-hmm.
Anonymous, of course, no HIPAA problem, really.
Yeah.
But, if I want to know how this community works, if I want to know, for example, they do this by knee-jerk in cancer, right? Oncology is a study of demographics, right? So I collect all the data, and then I see what your chances are with this treatment and that treatment and so forth. Every doctor goes through this with every patient.
Right.
So you guys have the data, or at least a fair shake of it.
Right.
And you can help provide anonymous data to whoever is doing the research for clinical treatment or for drugs.
Right. That's
All
right.
this is invaluable. So when you collect it together in one place, it has this huge secondary benefit for all of us.
Absolutely. And you're seeing that play out all across the healthcare space. I mean, nationally, internationally. It used to be that just being able to share the data was a very big thing. Now, less and less that's a big thing because we're getting better at it. We know the way. There's a certain amount of inertia in that. But now as you start connecting all these different pieces of the puzzle together and you start having these bigger data pools and access to more data, what are you going to do with it, right? So you could just produce static reports on very standard things that you've always reported on, or you can go deeper and look for very meaningful patterns and trends that really can help you really address cost with a more fine-tuned
And
instrument.
causation.
Cost
And community vulnerability and
utilization.
connection. All
Yeah,
that.
you know, yeah.
You make studies like that.
You can
You
really.
just running the big data, making like they
Absolutely.
do with the university and all these scientific areas. You can do the same thing. It's the same process
Exactly.
of running big data.
It's very exciting. This is a very exciting field, one I
Yeah.
could talk about all day long. So
Okay,
very-
so
yeah.
the other thing, just one last thing is, if I made you two ladies co-queens, co-queens, as you
Right.
run the place, okay, you have
She runs the place.
total power.
I'm a minion.
Yeah, okay, well, I know how that feels.
Yeah, right.
So, what would you do in order to make, reach nirvana on this system, to make healthcare the best it can possibly be in the best of all
Right.
healthcare places? What would you do? Is it money? Is it legislation? Is it creation of new organizations, tearing down old ones? Is it a smack on the side of the head? What would you do? What do you need? What stands in the way of reaching, your dreams?
Well, I think it's all those things.
Yeah, probably
So that's my easy
combination.
cop-out answer. But
Yeah.
I think one, technology is expensive to implement. So funding is needed on a basic level. And I think, Joyce is getting very excited about the innovation. The innovation possibilities are great, but that it starts off with having access to the data. So now we're back to the inability to get the data, and that goes back to what's in the physician practice. So it's one doc at a time in Hawaii, one physician at a time across the islands, and
Yeah.
so funding is needed. One, I think legislation tends to support a common understanding and common strategic goals,
Yeah.
and I think there's something to be said for that. And maybe it's not legislation, but it's an agreement. Hospitals and there are many different ways to interpret accountable care initiatives that are going on in the community, and multiple hospitals in Hawaii have initiatives that are going on, and that still requires data. So I think physicians have to be able to share information together. They have to be able to support that. And I think that's important in addition to the funding. And I don't want to say a slap on the head, but, we do want to motivate stakeholders to participate and encourage them and inspire them, so.
I envy you both. You're in a great spot. You're doing great things,
Thank you. Thank
We'll
you.
have to do this again.
It would be great.
Thanks for having us.
It's been a
you.
pleasure.
It's been a pleasure for me. Christine Sakuda and Joyce Lignell. Christina is with the Hawaii Health Information Exchange, and Joyce is with the Applied Research Works, ARW,
Yes.
which is a health IT provider here in Hawaii, the state of health. Thank you so much.
Thank
Thank
you.
you.
Thank you very much for having us.
Absolutely.